Kalra sir. Honorable Speaker Dr. Rajasekhar Reddi will be introduced by Dr. M L Kalra sir. Over to Dr. M L Kalra sir. Ladies and gentlemen, friends in a new abode, I welcome all of you to CME number 877.
Dear friends, I am delighted to have received a very good trophy, and also Dr. Chauhan and team to make me once more moderator. To introduce Dr. Rajasekhar Reddi, he is one of the best orators we have seen in our group, one of the most handsome person also. So currently he is serving as Senior Director Neurology in Max Saket, New Delhi. He has been practicing for more than 20 years. He is a member of various national and international forums. I will not name, they are all in abbreviations, only Dr. Tulsi may know it. AAN, NSI, IAN, IES, I don't know any of them. Well, to cut short, he is one of us. He is one of our very good and favorite neurologists. I have sent many patients. Everyone was very, very satisfied. Regarding the topic, ये जो प्लेटलेट्स हैं, हम जब पढ़ते थे तो इनको कुछ भी तो नहीं समझते थे एक तरह से. Just platelets. Even today, most of my friends, practitioners, physicians, they just see in the report platelet count and forget about it. Although hematologists have more than 10 indices to follow what is happening. एक तरह से प्लेटलेट की औकात हमारे खून में रेलगाड़ी जैसी है. सबसे छोटे, सबसे शॉर्ट लिव, ज़्यादा से ज़्यादा 10 दिन चलते हैं. लेकिन ये कम हो तो खराब और ज़्यादा हो तो खराब. काम ना करें तो खराब. So how to tame them? How to work as per our wish? We have antiplatelets when we don't want them to aggregate. जैसे 18-144 लगा देते हैं, ज़्यादा लोग इकट्ठे ना हो, तो ऐसे नाजुक कंडीशंस में एंटीप्लेटलेट्स यूज करते हैं. So which one to use? There are too many. Dr. Rajasekhar Reddi, all yours.
Thank you. Thank you.
And thank you everyone again for being here. It is an honor and a privilege always to be part of this group. Dr. Chauhan was mentioning that I've done the first talk here maybe in 2006 or 7 when we started off, nearly 20 years. And one of the things I want to tell you, and all of you have taken out time on a Wednesday evening to come and be part of these talks. And 877 is really amazing. It's a tribute to all of you who taken out your time and you're involving all of us with you, and it's really a privilege to be here. One of the things I've learned in the last 20 years of my practices is the only thing I don't have is time. And honestly, when I see all of you make time for me and for a program like this, it's fabulous. Thank you so much again. And all of you, we've interacted because of the patients you've sent me, and I see so many familiar faces, so many people that I've seen in my room with someone else, and I want to thank you for all the support over the years. Thank you very much. Thank you. So I'm going to be talking about a very common topic. All of us are using antiplatelets day in and out. So I just want to ask everybody here, for patients in neurology, in terms of a stroke, how many of you choose dual antiplatelets? How many of you choose single antiplatelets? And if you choose a single antiplatelet, do you choose aspirin? Do you choose clopidogrel? Do you use a combination of clopidogrel, aspirin? And so what is the general practice that everybody has? So hands up for aspirin alone. Alright, excellent. So hands up for clopidogrel alone. And dual antiplatelets? Alright. And dual antiplatelets, typically, what is the average duration that we would like to give it?
21 days.
Excellent. So I think my talk is done. I'll move on. So wonderful. So, the thing here is that I'm trying to explain the logic behind why we have to be careful while using these blood thinners. And why, so antiplatelets have been there for eons, since the beginning of stroke. I think even before that, we've been using it for years and years and years. And there's been some evolution in our thought process in terms of how to use these drugs. So I'm going to talk a little bit about dual antiplatelets, when to use it, and what are the advantages and disadvantages of this drug. So the first thing is clopidogrel plus aspirin for acute stroke. This is the commonest combination we have. And what are the studies and what is the rationale, what is the logic that has led to this combination? So I'm going to talk about this case. This is an 85-year-old woman with sudden onset left-sided weakness. A neighbor calls from the apartment saying that there is an emergency. She goes to the hospital. She does the CT scan. There's no bleed. This is already 7 hours post. She has a very low, what is called an NIHSS, not a very high NIHSS. This is the National Institute of Health stroke scale. I'll go into a little bit of detail about that. A CT scan did not show anything. She is discharged, and so what is the right treatment in this situation? This is a common situation that we see day in and day out. They're out of a window period, they don't have much deficit, and what do we do with them? So this is the NIHS stroke scale. This is a 42-point stroke scale that everybody who has a stroke or is suspected to have a stroke must have. Now this is not easy to remember, so in the emergency there should be a copy of this. People should go through this, they should start ticking whatever they can. And this doesn't take a long time to do, it takes about 5-7 minutes. And over a period of time it's even faster. And then you score patients from 0 to 42. 0 means no symptoms and 42 means worst case scenario. So stroke severity can be classified according to these bands. If you have no stroke symptoms, it's 0 of course. 1 to 4 to 5 is mild stroke. Beyond that is moderate and severe stroke, as you see here. Okay? Now, what is the ABCD2 score for TIA? Are you familiar with this terminology? So this is called, for transient ischemic attacks, we use this score to see the risk of recurrence in the next few weeks or months. So you look at the age of the patient, which is more than 60 or less. You look at the blood pressure, which is 140 by 90 or less. You look at the clinical features. Is there only speech disturbance or is there a unilateral weakness? You look at the duration of symptoms, is it between 10 to 59 minutes or is it more than 60 minutes? And the presence of diabetes. Now, if you have a score in this which is 0 to 3, then it is considered a low score ABCD2. And in this, the risk of stroke at day 90 is about 3%. However, if you start having higher scores, it can reach up to 17.8% at 90 days. So if you do not identify this patient, the patient comes, says, you know what, I have a little slurring of speech, I became weak, I was weak for about 1.5 hours, but I've completely recovered, I have no problems now, I'm a diabetic, I'm more than 60, and his score is, let's say, 7. Then he is going to have about a 17.8%, up to nearly 20% chance of having a stroke within the next 90 days. So these are the people that you need to identify. You need to make sure that you know which patients to catch. Somebody has a very low ABCD2 score. I'm telling you all this because I'm going to give you a little context in terms of the studies that I'm going to talk about later. So basically what I'm trying to say is that 20% strokes are recurrent after an initial stroke in TIA. And paradoxically in neurology, I want to tell people here, it's important to remember that the most worrisome patient is a patient who is well. So if I have a patient who's had a stroke, who's recovered completely, he is the one who does not allow me to sleep properly because now I'm worried about losing function. If a person has stroked out, he's come after 12 hours, he's completely plegic, he's 0 by 5 power, there's nothing to do. So I'm least worried about that person. Whereas if somebody recovers, he is one. So this is what I want to give a message here. Unlike the heart, the brain is not forgiving. If the brain infarcts and gets damaged, you're not going to get function back easily, so you have to be super careful when you're dealing with this group of patients. So what's the backdrop of antiplatelets? Everybody knows aspirin has been used for years and years and years. There's a combination which is called Agrinox in the West. It's a combination of aspirin plus dipyridamole. This contains 50 milligrams of aspirin, 200 milligrams of dipyridamole in a combination. You give it twice a day. There was a study called ESPS2, European Stroke Prevention Study 2, in which they showed this was superior to aspirin alone. But there they used aspirin only 50 milligrams twice a day. So it's not really fair to extrapolate it against a conventional aspirin. But it showed that Agrinox was superior to aspirin, was superior to dipyridamole alone. And now, do we believe that the combination of clopidogrel and aspirin may work even better? So there were 2 trials done for this. But John, if I'm going to take too long, you have to tell me. Because this is a longish talk. The moment you want to cut out, let me know.
Sir, take your talk, complete your talk.
Take it.
No problem.
Okay. So the first trial, there are 2 trials which were done, and I want to talk to you about these 2 trials of the combination of aspirin and clopidogrel. Can they work better than the previous known combinations, such as aspirin plus dipyridamole? So there were 2 studies that were done. One was MATCH and the other was something called SPS3. Now the MATCH trial, the question was, in patients with recent stroke or TIA, is clopidogrel plus aspirin superior to clopidogrel alone in preventing ischemic stroke? So this was a large trial, about 8,000 patients, but this was as far back as 2004. So when I had finished my DM just then, and this was a trial that was published. And in this trial, what they showed, what a combination of clopidogrel and aspirin did not help in acute strokes, and actually there was a 3-fold increase in hemorrhages. So this was a matched trial which told us don't use dual antiplatelets. Now about 9 years later, they addressed this question again. Here they looked at lacunar infarct and they said is clopidogrel plus aspirin superior to aspirin alone in preventing recurrent stroke. And they enrolled about 3,000 odd patients, followed them up about 3.5 years. And this was again a double-blind placebo-controlled trial. Now I want to tell you that this is an important question they were trying to ask, and that's why they looked at it again at the end of 9 years. Initially after saying you don't give any kind of dual antiplatelets. Okay? So when they saw this, again they saw that there was no benefit of clopidogrel aspirin with a 2-fold increase in hemorrhages when you gave dual antiplatelet. So till 2013-14, till this trial was published, the story was don't give double antiplatelets, give single antiplatelets. If anybody gave dual antiplatelets to a patient with stroke, he was said, you're doing the wrong thing, you're going to cause a brain hemorrhage. But what they saw in these trials was early on after these events, when the patient had the stroke, early on after the TI and a mild ischemic stroke, they saw a marked increase in the neurological events which continued to remain, but the biggest increase was in the beginning. When they analyzed the MATCH trial data, again they saw that patients who had early treatment, which is within the first, let's say 21 days or 30 days, they did much better than the people who were treated later. So they started looking at the subgroup of patients. They said, look, there seems to be a subgroup that actually benefits. Should we look at this subgroup again? So they refined indications and they said, since stroke risk is highest in the first days to weeks after a TI or a minor ischemic stroke, and almost up to 11% of stroke over 90 days if you look at average, half these occur in the first 7 days. Because the situation during that time is that the strokes are unstable, there's more plaque instability, and because of this is going to have worse consequences. They decided to look at this question again, and they started doing these trials again, and they looked at very early stroke. So again, there were some major trials, and I'm going to split this into 2 parts: clopidogrel plus aspirin versus aspirin or clopidogrel alone, and there's going to be ticagrelor, which all of you are very familiar with because all of you work closely with cardiologists, much more closely than I do. So I know that all of you are familiar with that, but neurologists, not so much. We're not using it that much, but I'll tell you why. So the 2 trials were chance in point for clopidogrel plus aspirin, and I'm going to talk about the Socrates and the Thales trial later. Now, what are the chance in point trial? What are the key questions that they asked here? They said, in a patient with acute mild ischemic stroke or TIA, high-risk TIA. High-risk TIA means ABCD2 score more than 4. I've explained the ABCD2 score to you already. is clopidogrel plus aspirin superior to aspirin alone? And this was again a double-blind placebo-controlled trial. Here, they looked at, you see the two differences here. Chance was done only in China, okay? And so this was a 300 milligram clopidogrel loading versus placebo along with aspirin 75 milligrams per day. I told you the inclusion criteria about TIA or high risk TIAs or a very mild stroke, NIHS less than 3. And they looked at 90-day stroke outcomes, okay? Now, point trial was conducted because the entire chance trial of 5,170 patients were all Chinese. So the whole idea was that this is published in NEJM. So these are not small trials by any stretch of imagination. They were well done trials. And so you're comparing this to point trials purposely did not include any patients from China. They looked at patients for the rest of the world. Okay. And they gave, here the difference was, they gave 600 milligrams clopidogrel loading. And they showed that in chance, there was some benefit in early stroke. So they started saying that if you had a mild stroke or a high-risk TIA, a dual therapy with these two medications was preferable to a single monotherapy with aspirin at a slightly increased risk of bleeding. And they've seen the safety outcomes here. I won't go through the details. And even in point, the major ischemic event was significantly lower with the dual antiplatelet therapy with very marginal increase in the bleeding. So if you looked at this over a period of time, most of the events which were neurological occurred early and bleeding occurred over the 90 days. So now the guidelines from the US, from Europe and in Canada, all three centers where we believe that stroke is treated with great, so they are very, very worried about stroke. Because if a person gets incapacitated, is on bed, he is a burden to society, he is a burden to the healthcare system, insurance pays, there's a lot of, there are billions of dollars lost in revenue because of people like that. So they want to do everything to make sure that so they recommend that for the first 21 to 30 days, you please use dual antiplatelet. Some people can use it up to 90 days. But the conclusion of this was that clopidogrel and aspirin is an effective combination when initiated as soon as possible after a mild ischemic stroke, so NIHS 5 or less, or a high-risk TIA, which has ABCD score more than 4, who is not being treated with thrombolysis or thrombectomy. 21 to 30 days seem enough, but we use it sometimes for up to 90 days because the point trial used it for up to 90 days. Outside of this period, the hemorrhage risk due to clopidogrel plus aspirin outweighs any benefit of reducing it. So after you do not want to use this medication at all. So now I'm going to quickly go to ticagrelor versus aspirin to compare, because now obviously this agent wasn't there at that time and this agent came a little later. Now what is the advantage of ticagrelor? Basically clopidogrel is a prodrug, okay? So it gets converted to clopidogrel in this thing. And here what happens is that you need the CYP2C19 systems you need the cytochrome systems of the liver to activate this prodrug to a drug. Ticagrelor bypasses all this and can act directly. So that's theoretically advantage of ticagrelor over clopidogrel. So I've explained the major clinical trials for clopidogrel plus aspirin. Now I'm going to go for ticagrelor and aspirin. There are two trials, Socrates and Thales. These were the two trials that were done. And the key question they asked in these trials were, in acute mild ischemic stroke or high-risk TIA, the same question as clopidogrel, is ticagrelor superior to aspirin in trying to prevent subsequent stroke or death? And now you can see, as compared to the year 2000, when they could sort of randomize 4,000 or 5,000 people, stroke trials are now getting into 13,000, 14,000 people. So you're seeing a much larger number of patients from 674 international sites. So good representation all over the world. And what they showed was there was a benefit in stroke, MI or death, but they did not reach a statistical significance. They said they just fell short of it. And when I say that if you have a p-value, which is less than 0.001, you'll get a p-value of, slightly more than that, and then you're out of, statistically you're not. The same thing happened for any outcomes they looked at. So Socrates itself was a negative trial. But they looked at some predefined groups in this trial. They saw that patients who had been on aspirin, so this was a trial of ticagrelor versus aspirin, okay? They saw the patients who were given ticagrelor, who had been on aspirin earlier, did better than aspirin alone. And that's when the combination started. And they started thinking that look, maybe, so maybe that this is the way we should go. So they looked at the next trial, which is the Thalys trial, in which they looked at mild to moderate strokes or a high risk TIA, and they said, is dual antiplatelets with ticagrelor plus aspirin superior to aspirin? Again, you'll see about 11,000 patients. And the study design was very similar. They looked at whatever needed to be done, and here they saw that there was a significant benefit in terms of reduction of all stroke outcomes and all causes of death, and even in secondary outcomes there was a benefit. There was some risk of bleeding, and you looked at this, when we talk about bleeding, we use a classification called GUSTO, in which there is severe, moderate, mild, and we only worry about severe GUSTO bleeding. We're not terribly worried about moderate or mild. There was some increase in that, but there was enough to tell you that you can consider this combination. So they looked at the safety outcomes, and I'm just going to tell you that also in this study they saw that anybody who had a significant carotid stenosis did better with ticagrelor plus aspirin than aspirin. So that was the second takeaway. The third takeaway in this trial was that people who had more disabling strokes did better with ticagrelor plus aspirin as compared to aspirin alone. So if you compare clopidogrel and ticagrelor, what do you really see? Okay, and I'm going to talk about this little bit. We have this test available. Okay? It's called a CYP2C19. It's called loss of function allele, which we check. If you have a genetic problem with this, typically what happens is clopidogrel doesn't work for you. So you will get recurrent strokes. If you do not have this, sometimes clopidogrel works too well and you will bleed. So that is the problem with this. And so there was a study in China trying to check this before you give a patient clopidogrel or ticagrelor. They looked at what is called a loss of function allele, and they looked at, this is called HOPR, okay? This is called high on treatment platelet reactivity. When you give this drug, you want to see whether the platelet reactivity is reduced. So if you have a high on treatment platelet reactivity, means that the drug isn't working very well. So I'm not going to confuse you too much with this, but by and large what they did was they compared these two and they found that ticagrelor was actually superior to clopidogrel. But it did not translate into clinical outcomes. Hence, in neurology we're still a little more favoring clopidogrel because of the what we call the safety parameter, so to speak. This was another study. They looked at chance to clopidogrel plus aspirin in high-risk patients with acute, and here, like you can see here, I don't have a pointer, do I have a pointer here? You can see here. You see this CYP2C19 loss of function allele carriers, and they compared this group. They looked at ticagrelor plus aspirin versus clopidogrel plus aspirin. And this was a chance to try. Again, they showed that ticagrelor was slightly more beneficial. Interestingly, a lot of these trials are coming from China. And they showed that ticagrelor was associated with more total bleeding events, slightly, modestly lower stroke risk when you gave ticagrelor. So I want to just tell you that this is really my last slide, and I'm not going to take much more time to tell you that in patients with ischemic stroke or high-risk TIA, 30-day treatment with a combination of ticagrelor and aspirin reduces the risk of composite stroke or death. And this is the NNT is 92, and the number needed to harm is 263. NNH is, so for every 1,000 strokes patients, you're going to save 11 strokes or deaths prevented with a combination, but you also have 4 hemorrhages. And as a result of this, it's actually approved for use in this setting. Also, I told you earlier, in patients who have significant carotid disease or patients who have, so we use it for patients who have significant carotid disease. We're using ticagrelor and aspirin as compared to clopidogrel and aspirin, and in patients who have very severe disabling stroke. So basically, my whole idea of talking to you today was that by and large, the whole idea, I'm not talking about AF related stroke, we're talking about antiplatelets in stroke. The number one treatment still remains aspirin. You want to use clopidogrel as an alternative aspirin, it is great, it works very well, except the cost was an issue in the West. That's why they promoted aspirin, but if you want to use clopidogrel, that's fine. When you come to combinations, there are two combinations which are available, clopidogrel aspirin, and as you can see that the people who have done the program for us today have a great combination. I use this drug a lot. It also is combined with a statin, so you just need to give one pill, it's a poly pill. And we have the other alternative, ticagrelor plus aspirin, so clopidogrel aspirin in patients who have significant ICA disease or have a severe disabling stroke, understanding that there could be slightly more risk of bleeding as compared to clopidogrel aspirin. So I want to thank you all for a very, very patient listening. Thank you.
लाइट जला इधर की भी लाइट जलाना
Kindly put the lights on.
Dear friends, we must acknowledge it was one of the very good talk, although full of studies. Dr. Tulsi is fond of studies. We usually take the take-home message only. We don't remember the numbers, how many patients. Sir, I'll set the ball rolling. My comment, just to confirm from you, ticagrelor is the only medicine which has a reversible effect, reversible antiplatelet effect. All others have an irreversible.
So,
you're right, sir. So we have that advantage, but the only thing is once in these patients, when any of these patients who are on these drugs, once they have bled, that is the time when we're talking about it. So the bleeding risk, once it happens, then if you have a major bleed by that time, doing anything more for that will not really be of much clinical use. That's our major concern. Because like we have with anticoagulation, at least you have this option, okay, you have a minor bleed, here once bleeding occurs, you don't have a reversible effect. Bleeding itself can be drastic, so we have to be careful.
Contrary to my this statement was, if we have to stop antiplatelets due to any procedure, so aspirin and all others have to be stopped at least 1 week before, because the effect will last, it is irreversible. For ticagrelor, it is two days only, because the effect lasts at the most 2 days, 48 hours. Sir, ABCD2, I was searching, is there any added disadvantage of smoking and lipids? It was not there. So are they not high risk TIA patients?
So the studies that were done were included only these criteria, and I completely agree that all the other factors you mentioned are also very important in this sort of situation. So I have no question that smoking and dyslipidemia would be risk factors. Because the study had this and showed these outcomes, we have to follow that. But we cannot score them in addition because of that. There's no ABCD2 plus.
Right, sir. Like we have PT-INR for having seen the effect and efficacy, whether plus or minus in anticoagulants. So do we test periodically at least for the effectiveness of the platelets, single or dual antiplatelets? Are we seeing for the effectiveness of the treatment being given? That aggregation testing.
So, platelet function testing is not common. We are not doing it routinely. And this thing I mentioned about high on-treatment platelet reactivity, HOPR, is the standard of care to try and assess platelet function. So we don't sort of do it routinely because these are difficult to replicate in routine clinical practice. Platelet counts are of no relevance because none of these things are going to cause thrombocytopenia or anything such. They have loss of platelet function. So we know that antiplatelet effects will last to, the conventional ones last for about at least a week, maybe even 9 days. So we don't really test for platelet function even while doing antiplatelets. I was telling you about the CYP2C19 loss of function allele. we have a test for that. We can do that check. And if a patient, let's say, is stroking again and again on clopidogrel, you can actually check for that, and you can say, look, this is a problem, so maybe he's a better candidate for ticagrelor rather than clopidogrel. There will be husbands of doctors who, some of whom will work in Max, who I have treated by checking these facts.
Sir, very nice presentation. It's always a treat to listen to you, sir. Always looking forward to your talk. Sir, you rightly said that the use of dual antiplatelets is in practically two settings. One is the non-cardioembolic minor stroke and high risk TIVs. Sir, in practical, there are other indications also, like see a patient mild eye care, include mic or a severe eye care. Then also I think we will require dual antiplatelets. And another setting is that if the patient is post-stent, he was done capital stenting, then also he needs to be on dual antiplatelets.
Absolutely. So, I completely
Agree with you. Sometimes, all these are for very clean, treatment-like patients. Now, if you have a patient, let's say, who was on clopidogrel and had a stroke, and he was compliant with the stroke, you would probably add aspirin for him. And then you have two choices at the end of 1 month. Either you stop the clopidogrel, continue aspirin alone, or you continue both. Most of us tend to choose using dual antiplatelets for longer periods if they have aspirin failure or clopidogrel. So these patients, if they have had a stroke on a single antiplatelet, we don't typically stop at 1 month. You also mentioned that we've had, for example, a stent. For a period of 6 months, we would use dual, and then we may consider going to a single antiplatelet after that. And typically we give much higher doses, we give 300 milligrams of aspirin with sometimes clopidogrel, and in that we use only Plavix sometimes because we're worried about the other things, because we don't have a stent. And then you make it 150, 75 at 3 months, then you make it 75, 75 at 6 months, and then you make it completely go off one of them and completely keep only on a single antiplatelet. So there are an intracranial disease also, somebody with a very high grade M2 narrowing, M1 narrowing. We don't usually stop the dual antiplatelet, we just continue.
Sir, wonderful lecture. I just wanted to ask some basic questions, sir. I went through the trials. Some trials used aspirin 75, some trials used aspirin 150 milligram, and some trials even used aspirin 325 milligram. Sir, what is the ideal dose? And it has been estimated that you should use a higher dose of aspirin in CVA, in brain stroke, as compared to acute coronary syndrome. Sir, your take on that?
So the antiplatelet trialist collaboration, which was published as far back as about the late 1990s, said that between 30 milligrams and 1200 milligrams of aspirin was efficacious. But they found that the sweet spot was between 75 to 325. Anything more than 325, you had efficacy at too much risk of side effects. Anything less than 30 milligrams didn't really work. So the cardiologists prefer 75 milligrams. They think that that's sufficient. Neurologists have always preferred 150 to 300. The Americans use baby aspirin 81 milligrams, and most of their data is used. We had a drug called Loprin DS, which was 162.5, which we now don't have anymore. We don't get it easily, but we used to use that a fair bit. But for me, I think completely right, Dr. Chauhan, we would like to use a minimum of 150 milligrams by and large. If you're in dual antiplatelet territory, then we sometimes go to 75. But as a monotherapy, we do not want to use only equals to 75 within our comfortable.
Sir, I wanted to ask you a simple question for our physician friends. If somebody has a recurrent stroke, do you go for a stronger antiplatelet therapy, dual antiplatelet therapy? And what is your experience of using aspirin, antiplatelet, and hemorrhagic strokes?
So, I use ticagrelor mostly in a setting of mostly I would imagine in stenting in those kind of patients where I think that there's significant carotid disease. By choice, we are more comfortable with clopidogrel because we've been using it for a long time. So there's the added advantage of what they are trying to show us is offset by a slightly increased risk of bleeding. So most of the patients who are on clopidogrel would be often patients who are planning to bleed from the cardiologist. And as a result of them being on this medication, as a result of a cardiac indication, I would manage them. I myself don't choose this drug very much.
I want to ask you a question.
Thank you so much, Dr. Chauhan. Thank you so much. Dr. Reddy, thank you so much. I'm Dr. Chakravarti. Thanks a lot for taking my mom, say about 10 years back, and successfully treating for that. Regards for that. My question is, we get, I'm a pediatrician by the way, so we get CBC course done left and right, almost for every kid. Once in a while, the range comes, say about 5 lakhs. Platelet, I'm going to platelet count. It's a highlighted one. The diameter reports are 1.5 to 4.5 normal. The parents might get penalty. Do we worry about that? You said platelets are dual source. Either ways, they are wrong. Do we treat or do we worry about that? Or in kids, I'm talking about 7, 4, 8 years of age, the count comes about 5.5, 6 lakhs. What's your say on that?
Not a concern at all. So up to 10 lakhs, we don't worry about thrombocytopenia.
Okay.
One.
Okay.
Second is that if you want to use a small dose of aspirin at a month, for children, I would probably avoid it because of Ray's syndrome.
Because I tell them reassure, I only reassure them, nothing to worry.
Absolutely.
Higher platelets are better than the lower one.
Correct. But like I said, even in adults or children, up to 10 lakhs, most hematologists are not concerned.
Okay,
Number
thank you.
one.
Thank you so much.
Second is we use aspirin in adults and hydroxyurea sometimes to reduce that. But in children, I would want to use aspirin because of Ray's syndrome.
Thank you so much. Thank you so much, Dr. Reddy.
Yeah, Dr. Reddy, considering that clopidogrel resistance is very common, so can we identify those patients by a specific test? So in those patients we can give other.
So this is the test I was telling you, sir. It was CYP2C19.
How specific is it?
It's a good test. It's CYP2C19 loss of function allele. For these loss of function carriers, we have this test available, and we do it all the time. So, we do it only for people who fail. So if you have a patient who's on clopidogrel, you think he's still having resistance, it's worth it.
Why? Because the clopidogrel resistance is very high. So why don't we do at the start of the treatment? Because considering that failure is very risky to the patient. It can cause distant thrombosis or maybe I'm not a physician but something like that. So why don't we do the test at the start of the clopidogrel?
So if you saw that study, sir, the chance 2 वाला जो last study था, clopidogrel plus aspirin versus ticagrelor plus aspirin, they separated patients basis this. And they followed these patients up and they saw that at 90 days, ticagrelor group was slightly superior to clopidogrel at a slightly increased risk of bleeding. So even when we segregated this, in studies we are not able to prove it. But in a clinical scenario, we have a problem.
Sir, when we talk about CVA or ACL, apart from antiplatelet, another important consideration is the plaque stabilization. And there comes the role of statins. I would like you to talk about your usage of statins in CVAs, recurrent CVAs and TIA.
So I think that the convention is to give, at least initially, a reasonably high dose of a statin. And it would be studies such as Sparkle, stroke prevention with aggressive cholesterol lowering, use 80 milligrams of atorvastatin. But we see that if you start using those dosages, a lot of people are going to get muscle aches, pain, sometimes hepatitis, inhibition of CPK and all that. So by convention, I would use initially at most 40 milligrams of atorvastatin. And if I'm using rosuvastatin, I would use 20 milligrams. I have not had an issue because of these agents. Now let's think about loading with statin and trying to make sure that plaque is very stable right at the beginning. I don't think that is clinical We've had situations when the sonographer tells us you have a soft plaque. Even in those cases, a moderate these doses of statins will be sufficient. We don't feel the need to want to get more than this.
Sir, you talked beautifully about the dual antiplatelets, whether it is aspirin with clopidogrel, aspirin with ticagrelor. Sir, I wanted to ask you, is it true, we are usually told once on a dual antiplatelet, once on a dual antiplatelet, always on a dual antiplatelet.
That's the message I was giving today, that the whole idea of dual antiplatelet therapy in a treatment-naive patient is to not give it more than 30 days, and at best to give it up to 90 days and then switch to a single antiplatelet. Because studies have not shown, and like people have mentioned, there are certain exceptions to that, which we do. You know, single antiplatelet failure because of the high grade intracranial disease, things like that we would do. Otherwise, typically we are supposed to go back to one. The other combination that you mentioned in this was aspirin plus dipyridamole, which is available as a drug called Areno in India. But you know, sometimes what happens is that studies have shown that these drugs work, but sometimes they're not very popular among people. The only difference between the international Actinox and the Areno was that the dipyridamole in Areno was not extended release preparation. So because of that, people said that no, it's not the same as people from outside. So we stopped using it. But otherwise, that's also a good option for a patient to face that. Patient comes with stroke and has 150 milligrams and he had a stroke. You can switch him to an Areno.
Sir, one of my friends, Dr. Jitendra Saxena, he asked me, sir, I am not very comfortable studying all the trials. I don't have the time, I am a very busy practitioner. He sees about 500 patients in a day. Sir, यार तालियां बजा दो यार सर he said कि डॉक्टर रेड्डी से एक सवाल पूछ लो आप कि सर आप ड्यूअल एंटीप्लेटलेट डालते हो पेशेंट को क्लोपिडोग्रेल एस्पिरिन पे डालते हो कितने दिन के बाद बुलाते हो और ये असेस करते हो कि इस पेशेंट को मैं सिंगल एंटीप्लेटलेट पे डाल सकता हूँ या मैं जिंदगी भर उसको चलाता रहूँ उसी के ऊपर और क्या मुझे उसका कैरोटिड डॉपलर कराना पड़ेगा बार बार ये देखने के लिए कि प्लाक कितना बढ़ गया है या नहीं बढ़ गया।
तो आपने बिल्कुल सवाल बहुत सही है। इसमें देखिए ऐसा है कि आप जब दे रहे हैं ये दवाइयाँ तो जैसे मैंने कहा कि अगर पेशेंट को पहले कभी कुछ नहीं हुआ तो आप सिर्फ 1 महीने के लिए पर एक अगर दवाई ले रहा था और उसके बाद अगर स्ट्रोक हो जाता है तो 2 दवाइयाँ देनी है और कई बार ये लंबी चलती है। अगर ब्रेन की ब्लड वेसल इंट्राक्रेनियल वेसल्स में बहुत सिग्निफिकेंट डिजीज है तब भी आप 2 दे सकते हैं और वो भी लंबी चलती है। तो ये थोड़ा सा मतलब हमें ट्रीट करना पड़ता है रियल वर्ल्ड में। बट अगर आप स्टडीज को देखें तो ये कहा गया है कि 30 डेज के बाद स्ट्रोक के बाद अगर आप 2 दवाइयाँ दोगे तो इसका कोई फायदा नहीं। दूसरा मैं आपको कोरोनरी ये बता रहा हूँ कि ये सारे स्ट्रोक के जो पेशेंट्स थे ये माइनर स्ट्रोक के पेशेंट तो इनके और ये TIA के पेशेंट जहाँ पर मेजर स्ट्रोक हो जाता है जहाँ पर आप NIHs 8, 9, 10 और ये बहुत मेजर स्ट्रोक नहीं होते बट लार्ज साइज मॉडरेटली लार्ज साइज अगर इम्पैक्ट है तो फिर ये रूल्स अप्लाई नहीं करते तो उसमें तो सब आपको एक ही सिंगल एंटीप्लेटलेट देनी होगी। अभी लगता है कि बहुत बड़ा स्ट्रोक है इसलिए हम 2 दवाइयाँ देंगे एक्चुअली दैट इज काउंटरइंट्यूटिव आपको वैसा नहीं करना है। हेमरेजिक ट्रांसफॉर्मेशन के रिस्क उसमें अधिक होते हैं तो आप कम दवाइयाँ देंगे जब बड़ा स्ट्रोक इसीलिए इन्होंने माइनर स्ट्रोक्स चूज किए थे फॉर ट्रीटिंग विद डुअल एंटीप्लेटलेट। मेरा ये कहना है कि माइनर स्ट्रोक इज वेरी इंपॉर्टेंट क्योंकि मेजर स्ट्रोक नहीं होना चाहिए। वो भी अच्छी बात है कि इनके लिए थोड़ा सा हम ज्यादा करें rather than some given।
सर आपने बड़े स्ट्रोक में फिर एस्पिरिन 300 जाएंगे आप और क्लोपिडोग्रेल 600
नहीं आप बड़े स्ट्रोक में एक सिंगल एंटीप्लेटलेट कंटिन्यू कर सकते हैं। लोडिंग आप 300 मिलीग्राम एस्पिरिन से करके उसके बाद 150 मिलीग्राम रेगुलरली कंटिन्यू करें उसमें कोई प्रॉब्लम।
सर आपने कहा अपने लेक्चर के शुरू में that these guidelines apply to non-cardioembolic stroke. सर अगर कार्डियो एम्बोलिक स्ट्रोक हो तो क्या एंटीकोगुलेंट देना जरूरी है?
अगर एट्रियल फिब्रिलेशन है नंबर 1, या आपको लगता है कि पेशेंट को कोई LALB क्लॉट था या बहुत लो इजेक्शन फ्रैक्शन है, स्ट्रोक टेरिटरीज मल्टीपल टेरिटरीज हैं जो आपको पता है कि ये सब कार्डियोकॉलिक ही हो सकती है, क्योंकि आपके पास ये नहीं कि यहाँ से भी लेफ्ट साइड में चला गया, ऐसे तो जा नहीं सकता। तो अगर आपको पता है कि इस तरह की चीज़ें हैं तो आप एंटीकोएगुलेशन चूज करेंगे। एट्रियल फिब्रिलेशन इज द ओनली इंडिकेशन फॉर अ नोवाक एट द मोमेंट, और बाकी जो चीज़ें हैं जिसके लिए हम एंटीकोएगुलेशन देते हैं वो कन्वेंशनल एंटीकोएगुलेशन होना चाहिए, बट हम कई बार उसमें भी आजकल हमने नोवाक यूज़ करना शुरू कर दिया जस्ट फॉर ईज ऑफ गिविंग, बट strictly speaking we're not supposed to.
I want to ask something. If you have a cardiac patient already on dual antiplatelets, taking clopidogrel and aspirin both, and suddenly you are driving and you feel you have a TIA, you are not very sure, you just get a little bit slurring, but you have the medicines with you, you think you should take more of aspirin, more of clopidogrel, anything you should do before you reach the hospital, or you are sure whether you have really had a TIA or you have had a stroke. Like being doctors, we usually keep these things in our cards. We keep sorbitrate, we keep clopidogrel, and we keep aspirin. But then we can't decide actually whether I should take 75 more of aspirin or I should take 300 of clopidogrel, or maybe I'll take a
So typically one would not like to treat your, anyone who's had a stroke symptom at home without imaging. Now I'll tell you why. What happens is a lot of these transient symptoms. So they've done a study where patients came to hospital with neurological deficits, and post-DM doctors were asked to differentiate clinically between hemorrhagic and ischemic stroke.
Exactly, I wanted to ask that.
And when they did that clinically, they got it wrong 1 out of 3 times. So you have a situation where a post-DM person is making an incorrect diagnosis 1 out of 3 times. It's probably prudent not to give yourself anything, because you also reduce the chances of being given an intervention. क्योंकि अगर God forbid stroke हो जाता है और आपने अपने आप को already antiplatelet में load किया हुआ है, तो thrombolytic therapy उस situation में देना becomes a challenge. क्योंकि हाँ जी, so unlike the heart where you want to do something, reaching the hospital is the best.
In suspected MI you can give, but not in stroke.
Correct. Yes. I mean, I'm not the best person to talk about MI. So आप लोग मेरे को बताइए देना चाहिए तो मैं.
You should not give unless CT is done.
Correct. Absolutely. Yes.
Hypertension को नहीं करना होता है. A very quick comment, a praise and a question. All the 3 things in one, by a case example to all of us.
Dual antiplatelets.
Dual antiplatelets. And he had worsening of symptoms of neurological symptoms. I referred to sir again and again, multiple MRIs to everything was done. I was like, something is amiss. I could not have GP ordered again a repeat CT or an MRI. Sir ordered a repeat CT and MRI. It turned out to be a subdural or chronic kind of a evolving one. Sir managed it very nicely. My question comes, sir, again in these minor ones which happen with TIAs, this is what we are discussing. This was again a double-edged sword, right, sir? So, this is what we have been discussing, but I think it kind of proves the point that it's a very grey zone which we have kind of.
Absolutely. This is a very classical example of why. So Dr. Manish referred this gentleman to me. He was in Calcutta in February this year. So he has a minor stroke. He is traveling alone. He goes to a hospital. He doesn't tell his wife. He gets admitted. They put him on dual antiplatelets. Now Feb onwards till now, he continues the dual antiplatelet and then continues to have some symptoms, which he started saying that look, I'm not okay. But he didn't have anything. So I said, what we'll do is we'll repeat an MRI and we will do a DSA, because if you're having these recurrent speech arrests. So we put him into the hospital thinking we'll do a DSA, and I did an MRI just to make sure that of course we have to do that in a massive subdural. And he was on dual antiplatelet, so we couldn't operate him for 1 week.
Yeah, 1 week he was. But why on previous MRI subdural hematoma?
No, so first initial MRI was normal. He was treated correctly with dual antiplatelet for a speech arrest, but it should not have gone on for this duration. You should have stopped in 3 weeks.
Our Guru wants to ask a question.
Sure. Yes.
There is no question. Good evening, Dr. Reddy. Very nice talk. You platelets and given the insight how to keep the patient, how not to do it. So my question primarily post-stroke, ischemic followed by hemorrhagic stroke. The first question. And then platelets are in only equal speed is 75 mg. Equal speed are the basic medicine like statin and antihypertensive. Generally condition is okay, but there is a residual effect of right side antiplatelets, which I think should remain. So how long should we continue the equal speed, or should we add any other antiplatelet, or is there need to increase the dose of antiplatelet? Or is there any chances of repeat recurrence of hemorrhage post equal speed?
So this is a patient who's had an ischemic stroke?
Ischemic stroke followed by about say 8 months diagnosed hemorrhagic stroke.
Hemorrhage stroke, ठीक है. So देखिए, basically what happens is hemorrhage overrules ischemia. Number one. So once you've had hemorrhage, you're going to be very cautious. So if a patient was having an ischemic stroke and then goes on to have a hemorrhage later, you want to reassess and make sure that there's nothing else. Sometimes people have microbleeds. As you know, long-standing hypertension, you can get two pathologies in the brain. You can get lipohydrosis, which is there, or you can get Pouchot's aneurysm. You have small aneurysm. So now MRI can pick up these things. So you do a sequence of the MRI. Normally, you do it for every MRI, which is called a GRE or a SWI image, in which you see a lot of microbleeds. Sometimes these people with microbleeds are candidates you have to be careful, even while thrombolyzing. They are very high potential for bleeding. So if a person has those kind of changes, you probably do not want to increase the antiplatelet.
Should we repeat the MRI after duration? So MRI is done, there will go back to
So we must repeat, because see, at the end of the day, like I said, there are these susceptibility weighted images, which are the best type of image to pick this up. And this is also based on the kind of MRI you do. Some of these will use a software that has that, some of them will use a GRE image. And these are the best images to try and see bleeds or microbleeds. Now if you do a CT scan for these people, it's normal. CT scan will not show anything.
So you should repeat MRI, say, 1 year or 2 years down the line?
No, I would imagine that once a treatment decision has been made, you follow them up closely, and if they're symptomatically okay, that's the thing about stroke. There's a little bit of unpredictability, and you're not always going to get followed. But the best thing you can do is repeat an MRI again, make sure there's no high risk, otherwise you be careful about the blood thinners you're doing.
There is always a chance of recurrence of stroke. That is the average disease.
Right.
There is always been said, but they can recur. So in that, to prevent that kind of recurrence.
Recurrence of hemorrhage, sir?
Because of hemorrhagic stroke again.
Not terribly common. If the risk factors are controlled, it's not so terribly common. It's not true.
Thank you, Dr. Mathur. We request Dr. A K Bharat to ask this question.
Yes, sir. Hi, sir.
In OPD practice, it's so difficult to differentiate whether it's an ischemic stroke or hemorrhagic. So, in that particular case, what should we do? Should we refer the patient to you, or we start
Sir, if any patient has come in with any symptoms which are of new focal weakness or any kind of suggestion of stroke, then they should ideally be sent to a hospital. Because if they're a candidate for thrombolysis and all, that should not be used. So I think, if a person has come with a new onset neurological weakness, he should go into the nearest hospital.
Being made with the patient responsibility for the first time. You don't know about his history or anything. But he is having some stroke is there. We don't know whether it's
So no treatment should be given. No treatment.
So this means that all the cases should be referred to the hospital.
Or for an image. Or for an image. Stroke, you should actually 100% refer. I mean, if the patient says that my stroke is 5 days old, you could consider sending for an MRI and ask him to come back. But if he is coming within a window period, he should be in hospital immediately. If 10 दिन से मेरी ज़बान लड़खड़ा रही है, तो आप MRI करा के आ, कोई बात, that's fine.
All window period is how much?
Window period for IV thrombolysis is 4.5 hours.
4.5.
And for mechanical is 6 hours. We extend that window to 24 hours in certain situations.
Dr. Reddy sir, I have already given this to Dr. Kulshi sir. So his questions are down by 75%.
Okay. only one. So 8 questions to now 2 questions on.
So, Dr. Reddy, such a wonderful talk, always a pleasure to listen to you. So, this is an era of evidence-based medicine, and here we are talking about all patients with AIS, that is acute ischemic strokes, or TIS, not already on antiplatelets, should be treated with at least 325 or 150 milligrams of ASA immediately at the loading dose after brain imaging has excluded ICH, which is an evidence level A. And for patients who already received IVT, which is intravenous thrombolytic therapy, avoid antiplatelets for 24 hours and then advise after brain imaging has excluded secondary hemorrhage, which is an evidence level B. Talk us through that, sir.
Sorry?
Talk us through this.
Absolutely, absolutely, exactly.
Okay, sir, you talked about the DAP for 21 days, unless there are specific indications like, Dr. Padar, would you like to say, arterial stents, and symptomatic intracranial arterial stenosis. So, not 21 days here, but maybe at least for 3 months. See, DAPT for 3 months, a specific indication, sir. And patients who already are on antiplatelets and have a stroke. See, you remember that patient in the guy's hospital who had, who was on Brilinta and had a TPA and had an intracranial hemorrhage. Right? In spite of repeated blood transfusions, he couldn't survive. So what about this? This particular set of patients, are you seeing this? Patients who already are on Brilinta and given TPA, do they bleed? I know it's rare.
You're completely correct, sir. So any patient who is, see, the point is that after the onset of stroke, you should not give any antiplatelet before thrombolysis. If the patient is already routinely on antiplatelets and he comes in with a stroke, there is no data to tell us what will happen. So suppose that I put it this way. Somebody becomes weak at 4 o'clock in the morning and his routine dose of antiplatelet was the previous night at 9 o'clock, then it's fine. But if he gets weak and you give him a dose at 6 o'clock and bring him to the hospital, that's enough. So the risk of bleeding increases. Whether it is more because of ticagrelor or clopidogrel, there's no such. All of them are going to have additional risk. So you want to minimize. You don't take anything yourself. Come to the hospital.
Right. So I was deeply mystified by the Socrates and the Thales trial. Dr. Chauhan would know about that. So, Tika and aspirin or ASA better as compared to the clopy and ASA, especially in patients who who have large strokes or large vessel occlusions. So is this better, the Tika and ASA versus the clopy? Of course, we know they would probably bleed more, but the functional outcomes would be better.
If you have
the Socrates and the Thales trial.
Correct. So if you have a significant carotid atherosclerotic disease, that's one of the indications to consider using ticagrelor with aspirin as compared to clopidogrel aspirin. Again, for that period of time, for the conventional 1 to 3 months. Beyond that, there is no rational value of this.
Okay. So finally, let me ask you, sir. So if a patient is already on clopy and has a stroke, would it be reasonable for you to switch over to probably Tika instead of clopy?
you would probably, you could even consider clopidogrel plus aspirin. You don't need to test it with ticagrelor. You can do CYP2C19 loss of function allele testing for this patient, and if you do prove that, then you have justified it.
Wonderful, sir. Thank you.
Friends, all of you would agree, we had a wonderful session with Dr. Rajasekhar Reddi sir.